دكتور اسلام حضرتك سامعني؟
واحنا بس بصراحه بنظبط اليوتيوب لايف.
طيب اوكي. وانس جاهزين قولوا لي بس. اوكي
دكتور اسلام كده اليوتيوب اوكي يا دكتور اسلام. دكتور اسلام احنا كده جاهزين ان شاء الله.
بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. Welcome all in our presentation with starring glaucoma. Professor Dr. Ahmed Mostafa Abdul is one of the eminent name and stars of glaucoma in Egypt and in the world. And he will talk to us today about a tour in the glaucoma operations. So let us welcome Dr. Ahmed, and can start Dr. Ahmed, please.
Assalamu alaikum warahmatullahi wabarakatuh. Thank you very much, Dr. Islam. Thank you very much, Dr. Ahmed, for the wonderful effort. ربنا يتقبل منكم يا رب إن شاء الله. I know that in the last 2 months you have heard a lot about glaucoma, of course, and in all other branches of ophthalmology. So my lecture today is just a tour in the glaucoma operations. It is just what I really do in practice. And it will be a good chance for a kind of discussion and hearing other comments and questions rather than giving information, because I think the audience, the participants are so much loaded with information so far. So basically speaking, when we start managing glaucoma, we just classify the patients, whether it's an open angle glaucoma. With open angle glaucoma, we need to see the scleral spur clearly below the trabecular meshwork. So this is a typical case of open angle glaucoma, primary open angle glaucoma. And sometimes the Schwarz line is somewhat pigmented, as we see here. And this is the other scenario where the angle structures are not seen, just the basic angle structures are not seen. So it is just angle closure glaucoma, and it's usually, it comes in the chronic form, which is patients presenting with a picture like open angle glaucoma, elevation of the intraocular pressure, visual field damage, and optic nerve damage, but the angle is closed. So this is chronic angle closure glaucoma. And then this is a picture of a case of secondary glaucoma. As you see, we can see a lot of new vessels on the angle on the iris. So it's basically a case of secondary glaucoma. So when we go for a tour in the glaucoma operations, basically we need to know what sort of glaucoma we are dealing with. Now, this is just a roadmap I tried to put most of the procedures we really do. Now we have a surgical indication, and as you know, the most common surgical indications is the pressure that is not controlled despite the use of a maximally tolerated medication, and probably laser as well. And sometimes the pressure is controlled, but the patient is not tolerant with the medication. Sometimes the pressure is controlled, but the patient is not adherent to the medication. Sometimes the pressure is apparently controlled, but the visual field is deteriorating. So these are the classic indications that we need to go for surgery, and we should not delay the surgical, not leave the patient till the late stages of the disease, where everything is difficult for the patient and for the surgeon and for everybody. So if we have a surgical indication, we'll just sort our patients into primary open angle glaucoma or primary angle closure glaucoma, or a case of secondary glaucoma and refractory glaucoma. So secondary and refractory glaucoma, they are all together. And just let me ask you, if a patient is using the maximum medications and the pressure is not controlled, is that a refractory glaucoma? The answer is no. This is called uncontrolled glaucoma. A refractory glaucoma, it has another definition, as we will touch upon right now. Now, for primary open angle glaucoma, you have two options. It could be trabeculectomy or deep sclerectomy. So it could be a penetrating surgery or non-penetrating surgery. And actually, you cannot float between these two operations. You should select one of those and gain experience with time. And then if you go for trabeculectomy, the pressure might be fine, it's okay. or post-operatively the pressure might be high or the pressure might be low. So if the pressure is high, again, we have the options of suture lysis or the options of or needling. So we have to do something if the pressure is high. We cut the suture or we needle the blood. Now, if the pressure is low, we need to think, is that a leaking blood or over-filtering blood? A leaking blood means that the conjunctiva is leaking, so that the flow through the trabeculectomy might be fine, shouldn't be in excess, but there is a leak through the conjunctiva. On the other hand, it could be over-filtration, which means that the trabeculectomy is draining a lot of fluid from the anterior chamber. So we need to differentiate for that. Now, if we opt for deep sclerectomy, the major problem that we will meet post-operatively is high intraocular pressure, and then we need to think how to manage this high intraocular pressure by a process of goniopuncture. Now, if it is primary angle closure glaucoma, the decision is to do phacoemulsification. It is not to do trabeculectomy, just phacoemulsification. And then we can add something so that you can do phaco alone if it's just an early or following an acute attack of glaucoma, or you can add something like you can add goniosyncytial where you lyse the synechia, or rarely trabeculectomy, which is actually not recommended to add trabeculectomy to the phaco. So this is the management armamentarium nowadays for angle closure glaucoma. Please go for phaco. Now, if it is a secondary or refractory glaucoma, for secondary glaucoma, we need to treat the cause. So if the patient is uveitic, if the patient is neovascular, if the patient is something causing the glaucoma, a steroid responder, for example, so that we need to treat the cause. And so this is part of the management, is to attack the cause directly. And then you can treat the glaucoma if management of the cause is not satisfactorily reducing the intraocular pressure. To treat the glaucoma, we have all the options open, whether trabeculectomy, whether deep sclerectomy, whether to go for drainage devices or cycloablation, so that all the options, and definitely you should have something in your mind to decide which procedure is more suitable. But again, all the options, you are open for all options in this situation. And sometimes you have specific other procedures. For example, if the patient is neovascular glaucoma, then you need to go for PRP. If the patient is pigmented glaucoma, then you need to do PI. So this is the map of glaucoma that we practice all the time. Definitely there are some other procedures, but we are working on this roadmap for the majority of the situations. Let us just see some points related to trap. When we do trap, we like to have good exposure by corneal traction suture. It is usually superior. You can take it inferior, and we use it. We use usually Vicryl 7.0 on a spatulated needle, and then we open the conjunctiva, and then we open the Tennant's layer, like here. Then we should have a good exposure, like what I am doing now. Now, the best instrument we use is usually the crescent blade. And I start by doing like that, a horizontal incision at the back, and sometimes it's a bit posterior. I do trabeculectomy very infrequently, but again, it is better to be a bit posterior. And then we dissect. The point is that when it comes towards the limbus, we need to angle our hands. So this is very important. We should angle our hands upwards so as not to penetrate the anterior chamber. And then we apply the anti-metabolites. We can apply sponge, or we can do injection. But nowadays, I prefer the sponges actually because they are bringing me better and more diffuse blood. And we tend to push the sponges posterior as we can. And then we usually avoid the anti-metabolites touching the edge of the conjunctiva. My concentration is usually 0.4 milligram for a couple of minutes. And then paracentesis is critically important. And you can see drops of aqueous coming out that will help in gradual reduction of the intraocular pressure. One of the major complications of TRAB is to get sudden hypotony. And in this way, I avoid sudden hypotony. And then we will cut in the cornea, and then we will remove the periphery of the cornea. It's actually like corneectomy. You cut the periphery of the cornea till actually the junction of the gray and blue. And then we do peripheral iridectomy. And then we put 2 sutures, and then we inflate the anterior chamber. I don't like to leave the eye hypotenuse so that once I'm able to put pre-placed sutures, and then I inflate the anterior chamber immediately, and actually my heart does not stop beating vigorously until I'm quite sure that the anterior chamber is nicely formed. So these are the basic steps. The point is that please avoid sudden decompression of the anterior chamber by paracentesis, and you can have pre-placed suture to suture everything directly. And then this is called a releasable suture, and I can see a growing interest in this releasable suture. It's like that. After we do the trap, you can see from the PI, we take a suture superficially and here in the scleral tissue, and then coming from a tunnel done at the periphery of the cornea, and then we come in again, and then we push towards the base of the flap. Again, those sutures are a bit superficial. They shouldn't penetrate the anterior chamber or shouldn't be a full thickness in the flap to create a hole. It is just superficial sutures like what I'm doing here. So after that, we will come to one edge of the flap. I usually do that suture when I want to have good filtration as early as I can, so that I put one complete suture, and the other one is a releasable suture like that. And releasable, we will release this suture on the slit lamp. So I took now the bite, and all the bites are superficial again, and then I will make a knot with this loop. So I have one end here, and then we take like 3 throws, only 3 throws. Again, I can hold. So again, 3 throws, and then taking this, and it's like that. Only it is done in the direction of the suture, that's all. And then we will cut here, and then we leave this loop. Yes?
So the video is lagging, yeah.
It's not working?
It's very,
the video is not clear.
It was freezed, yeah. It was freezed, and now just coming frame by frame again. I think your internet is
poor. I'm sorry for that, actually.
It's working now. Yeah, it's okay.
Okay. Then again, I just yeah. So this is the releasable suture again, and then I'm taking it. And I think most of those doing trabeculectomies are familiar with this releasable suture again. And then we just make it tight. We close actually the flap. There are some different techniques so that you can have like 2 sutures, and then you can add a third one releasable. But I actually take one complete suture and a releasable suture. And again, you can see I cut it from here, and then we have the suture lying in the groove in the cornea like that. And then in the post-operative, we have the patient on the slit lamp, and then we can just we put some topical anesthesia, and we ask the patient just to stabilize the eye, and then we use the insulin syringe, but again we do like and then we cut the suture to get the loop, and then we just get it like that. Dr. Islam, is it seen or not?
Yes, okay.
Hello? Okay. So we release this suture on the slit lamp actually, and then we do some massage. So this is called the releasable suture. We frequently apply in cases of trabeculectomy. Now, in case it happens like that, a patient is coming with a scarred blood, so that the patient underwent a combined surgery, and this is a risk factor for scarring. The patient is actually diabetic. You can see from the kind of marks on the iris. And then what we really do, and then I'm doing a paracentesis in the first place because I need to inflate the anterior chamber after finishing the needling. And then we will go for the site of the trap. Again, I can see it as a triangular flap, and some suture is here. It was just a single suture at the apex. So what we actually do is that, first of all, if we are able to read on the slit lamp with the suture lysis, that would be nice. But if we don't have the lens, and then we can do it under the surgical microscope, we just get the insulin syringe, and then we can expect some blood here. But again, you cut the suture, and then you inject inside the anterior chamber to inflate the blood. Usually we put 2 sutures and then we cut 1 suture, but here I did a small trap and then I put 1 suture and I re-inflated the bleb right now, and it was a combined surgery. So when the bleb starts to show signs of scarring and flattening of the bleb, we will go for needling of the bleb. We shouldn't wait. Now, this is another situation. After a long period of time, sometimes the patient gets leaking from the bleb. And that happens actually with the application of antimetabolites, where we can get thinning, then leaking, and situations the patient will complain of frequent watering of the eye, and then he might have signs of hypotony like choroidal falls, drop of vision. But what we really do actually when we have an evident leak here, we go for removal of all the bleb. So again, we take care not to cut the sclera because the scleral flap is definitely very near to the conjunctiva here. We just cut this necrotic conjunctiva. I want to refresh the ocular surface with fresh conjunctiva. When I have a lot of leak here, which I don't need it in this situation, then I can put a kind of suture, and this is a kind of compression suture. I put it in the depth, in the area of the operation. It will hinder the aqueous coming from the eye, and then I will refresh the ocular surface with free conjunctiva, like what I'm doing now. So the long term, like months or years after the operation, you can have leak from the surgical site. So please prepare yourself to refresh the ocular surface with something new. You can do this also in the kids. The children are more liable to scarring if we go for an operation like the combined trabeculectomy, trabeculotomy. Sometimes the bleb does a scar, and you can see the signs of the corneal lines here. And then there is a trap here, and the pressure was not controlled. Again, we will do the same. We will just, you can see the bleb is completely scarred here. And then I can see the sutures, and then I do just a kind of massage. And then I inject something usually under the conjunctiva. It's the diluted mitomycin or lidocaine. And then I go for needling of the bleb. So we do needling of the bleb for children and for adults as well. We just take care because you go in between the blood vessels because you can hit the vessels and you can get a lot of bleeding. So just be aware of that, that you need to avoid bleeding as much as you can. Dr. Islam, is it seen or not?
Yeah, no, it is the video stopped. So let us make it on PowerPoint regular because I think your internet is not able to broadcast the video.
Okay, so that now I will
go
share.
to new share. Yeah, stop share and start new share and remove the mark.
Okay, I will do that.
It will be slightly frame by frame, but it will be better than freezing. Yeah.
Okay, so yes, okay, so I will do that.
Yes, you can start now, PowerPoint.
I started, yes. Is it better?
Yes, better, yeah. As I told you, it will be frame by frame, but we can get the idea.
Yeah,
Can we repeat the previous? Can we repeat the previous slide, please? Because it was freezed.
This one?
Yeah.
Yeah, that's when when we get leaking from the bleb. So this happens really years after the operation when the patient starts to complain from watering of the eye, and you can find a lot of leak from thinning of the conjunctiva. And under those circumstances, if the patient has received antimetabolites, the only solution is usually to cut this necrotic conjunctiva and then to cover the ocular surface with fresh conjunctiva. So that don't waste your time. If you see an evident leak using the fluorescein test, please go for refreshing the ocular surface. But here I saw a lot of fluid coming from the eye, and the patient had hypotony maculopathy. So I decided to decrease the filtration as well by putting this matrix suture, and then I will suture the conjunctiva. getting a healthy conjunctiva. And definitely the pressure in the postoperative period might be a bit unstable, but at the end of the day, the problem of the hypotony will be managed. So now the patient might get cataract, so that a patient underwent a trap, and you can see this bleb is a very ugly bleb, a very frightening bleb. So at the same time, the patient had developed cataract. So in these situations, usually you make the chance of doing cataract surgery, and then you cut this ischemic bleb that's about to explode, so that you just finish the cataract as regular. And sometimes you get a lot of fluid coming from the trabeculectomy, making the anterior chamber a bit unstable. But this doesn't happen. You go for your regular phaco. And then after you finish the phaco and implant the intraocular lens, now you can go for this necrotic conjunctiva, and then you cut it. The problem is you need to assess how are you going to cover the ocular surface, because now it's a big one, so that you need a conjunctival graft, because if everything is large like that, you usually cut the necrotic bleb and then to get a fresh conjunctiva and to refresh the ocular surface. So again, if the bleb is bad on the long term, you need to manage this as well. Now, if you look at this eye, when we do trabeculectomy and we can see bleb, perfectly working bleb, we usually warn the patient against some signs, so that we ask the patient, please, if you get photophobia, if you get lacrimation, if you get drop of vision, if you get redness of the eye, please come as soon as you can, because the patient might have developed endophthalmitis like this situation. And I met a couple of patients in my life, and they were injected intravitreal antibiotics and recovered completely. So again, you tell the patient, if you get drop of vision, if you get photophobia, and if you get pain in your eye, redness, please come as soon as you can. And I warn my patients about those. So this is a patient with post-trab hypotony. She was a female patient, high myopathy. Myopic patients are especially at risk. And actually, she was pseudophakic. And then I did the operation, and then I got this bleb, and the patient developed a low intraocular pressure with diffuse leak. So other investigations we do, yes, sometimes we go for OCT just to document what's happening in the macula, like here. And then, shall I leave my patient? No, I can't leave my patient, especially if there's a myopic eye. It will not recover spontaneously. So what I did, actually, I told my patient, the bleb is overworking. You have overfiltration. I need to manage this. And then I opened the surgical site again, and you can see a lot of echoes coming out. So in this situation, I will go for, and actually, I will suture this bleb, and then I will remove this necrotic conjunctiva to restore the ocular surface. So that's what I'm going to do, and that's what actually I did for this patient. But what happened, that the intraocular pressure remained low, and this was associated with drop of vision. So this is one of the sutures which is developed by Bollenberg. This is called a compression suture. It's actually matrix suture, but I put more than one matrix here, and then you can see if the bleb is a huge bleb, over-filtering bleb, you can compress this bleb with this compression sutures. So this is one of the famous sutures to treat over-filtering blood. You don't have to suture, you don't have to inject blood, you don't have to do anything. You can take this compression suture, and it will work efficiently. And the patient actually, her intraocular is now 10. So it's a beautifully working for over-filtering. Dr. Islam.
Dr. Ahmed, تفضل.
Yes, before I go to deep sclerosis, please, you can ask the participants if they have questions.
Yeah. If anyone have questions, you can raise his hand and or write in the chat.
So that I will move to from trap to deep sclerotomy. If we have questions related to trap, it will be more than welcome.
Anyone has questions? Yes, we have one. Yes.
Yes. I think I can read the
تفضل
question.
مؤمنة. دكتور مؤمنة تفضل.
Yes. دكتورة مؤمنة.
Okay, you can. I make the option now. You can unmute yourself, Dr. Ahmed.
Thank you very much. Thank you very much, dear doctor. But I have one question. When you
Yes.
remove the conjunctiva from the necrotic conjunctiva, do you graft
Yes.
the conjunctiva from the other side, or you bring the conjunctiva from the upper part of the eye?
That's a very good question, Dr. Ahmed. Thank you very much. I usually tend to not to operate on the second eye unless it is absolutely necessary. So that I just go usually for the lower fornix, and then I inject lidocaine, and then remove only the conjunctiva, not the tenons. But I actually tend to measure the defect that I want to cover, and I take the conjunctiva like 1 or 2 millimeters larger than the defect. But I take from the lower fornix in the same eye. And then if the lower fornix, there is a problem with the lower fornix, and then I might think of the second eye, but I actually think of the same eye.
Second question, sorry. When you have a leaking from the side of the sclera, do you suture the sclera to prevent the leaking, or leave the sclera when you put the second conjunctiva on the side of the trap?
So nowadays, Dr. Ahmed, we put compression sutures in actually, so that we don't open. So that in the old days, we just open the conjunctiva and explore the sclera and then put more sutures. But nowadays, we don't do that. We just suture, put the suture on the conjunctiva so that it will be on the conjunctiva and the sclera as well.
Okay, thank you very much, Doctor.
Thank you, Dr. Ahmed.
Hello, Dr. Ahmed.
Yes.
Thank you. Thank you for the great lecture. I have a question regarding releasable suture. If yes. I didn't need to remove it early, the patient IOP is fine. When yes. do you prefer to remove them, or you just leave them?
You just leave them. You know the point that the surface of the suture is epithelialized because you are having a groove, so that the suture is in the depth of these grooves, so that you don't have to do anything. If the pressure is perfect now, it's okay. So it is just like a reserve you have to manage in case the pressure is elevated, but you don't have to do anything if the pressure is perfect, definitely.
Okay, I have another question. I had this situation a couple of times. The patient is going fine for like a month or 1.5 months after the surgery with IOB around 8 or 10. And then the patient disappeared for just 1 week or 2 weeks and returns with a pressure of 20 or 30. I usually go for needling. Is there any value for removing the releasable suture and massaging at this stage?
Yes, yes. I think as long as you put anti-metabolite, and we usually do that, there is almost a chance for needling, but you can test that. What I do in these situations, I just start doing massage myself and to see if the massage is going to be effective or not. Because sometimes it doesn't work if we have a lot of scleral scarring. So I just do massage, and then I try from the lower lid, and then I try from the upper lid. And if I failed to elevate the conjunctiva, I will not go for massage, then I will go for suture lysis. But if the blood is beautifully elevated, and then I will allow my patients to do the massage and come. I will, in these situations, I will ask my patient to come like in a few days, just to make sure that everything is going fine.
Okay, thank you very much.
Yeah, you're welcome.
We have a question on the chat, Dr. Ahmed, from Dr. Sarah. How do we do the
Okay.
compression sutures? Is it above the conj or above the flap?
It's above the conjunctiva. It is above everything. So that you just take the conjunctiva from the corneal side. You can take from the corneal side, and then you bridge the blood and then suture to the epic sclera posterior to the blood, and you can get it from the side, from the epic sclera, but it's above everything.
Okay. So no more questions.
Okay.
We can proceed to the deep sclerectomy.
Good. Thank you very much. Now let us go for my beloved operation, which is really deep sclerectomy. Now, the secret of deep sclerectomy now, if you look at the diagram, this is the Schlemm's canal, and then underneath the Schlemm's canal, we have the trabecular meshwork. The trabecular meshwork is actually percolating, which means that the aqueous will go through it. So that if we just remove the floor of Schlemm's, then we will bisect Schlemm's canal, and then sometimes we remove the floor as well. And then what will happen, the aqueous will percolate, it's called percolation. And that's the situation, so that if you just leave the floor, it will percolate anterior to the Schlemm's canal. And then if you remove the floor of Schlemm's canal, you will help percolation more. So this is how deep sclerectomy works. And then the fluid will go to the subconjunctival space. It is, to my impression, deep sclerectomy is an external filtering operation. It's exactly like trabeculectomy, with a big advantage of having the eye not open. So that it is a filtering operation, so that you will have a bleb into the and with the aqueous on the subconjunctival space. But again, the eye is not open. This is the beauty of this operation. Now let us see how the operation is done. Actually, you open the conjunctiva, the phonic space, the flap. Sometimes we don't do a lot of diaphragm, and then after we dissect the first flap, and this is the first flap, and then we'll go for a second flap. And then the dimensions are usually 4 by 4. I go for a large flap, and then we need to see the blue color of the ciliary body. This is important. We just leave a very, very thin layer of sclera, and then we continue forward. And then as we continue forward, the end of the sclera is called the scleral spur. It's a sharp line, so that we need to see this sharp line. Then after we get to this sharp line, immediately we will get to Schlemm's canal anterior to this line. So again, I'm quite sure I'm here in the proper plane because it is a sharp line. And now I'm opening the Schlemm's canal. So anterior to the scleral spur, nothing except the Schlemm's canal, and then I enlarge the opening. Once the Schlemm's canal is open, now the roof is here. The roof is in this flap. And then this is the Schlemm's canal, the cut ends of Schlemm's canal. Now we are removing the floor of the Schlemm's canal. This will help more percolation. And then we will cut this deep layer. And here I'm leaving Helon. And then the surgery is actually end sutureless. Let us see another scenario. Now, deep sclerectomy is good for the young patients as well. And is very suitable for patients with advanced damage because of the extra set. Now, let us see again some other videos. And here I'm putting suture on the deep flap. So nowadays we tend to go more posterior, but you can see the aqueous will start to percolate. It takes time to appear to have good percolation. And then this is the floor of the Schlemm's canal in case I wanted to remove it. Now you can see the aqueous is coming. And then we continue this section. We need to see good percolation. Again, the eye is not open. You can see the iris, but the iris here is covered by the trabecular meshwork. And that's the beauty of this operation. I did not open the eye. That's why it's called non-penetrating glaucoma surgery. And then I will cut this deep layer, and hence the name is deep sclerectomy. Now what happens? The aqueous will come through this membrane, the trabecular meshwork that's continuous anteriorly with the descemet membrane, and then will fill the subconjunctival space. Now the flap usually contains the, this is the flap and contains the Schlemm's canal superficial layer, roof, or the endothelium. Now let us see more. I'm dissecting the first flap. It's like trabeculectomy. Deep sclerectomy is for open angle glaucoma. Sometimes I just keep waiting for the vessels, and sometimes the bleeding stops. Again, I'm now here in the periphery of the cornea. Then I will go for deep flap dissection. The deep flap is within the context of the superficial flap. And then to start dissecting the deep flap, again, I need to see the ciliary body. And then I leave a very thin layer of sclera. A very, very thin layer of sclera. Again, look at that situation. Scleral spur is a sharp line. Now I have this line, which doesn't look to me a complete line. So I'm deep, and this is probably the ciliary body. And then I will go more superficial. And then again, so that I can modify. The point is that I keep stretching on the deep flap during the dissection. This will help a lot. So again, you keep stretching the flap upwards. And now this is the scleral spur, a sharp white line. Once I see the scleral spur, and then this is the Schlemm's canal immediately anterior to the scleral spur. So this was the ciliary body. There is no problem in exposure. Just don't injure the ciliary body and nothing will happen. It might help even with the fluid going into the suprachoroidal space. And then again, I continue the dissection. Some adhesions are present here. And up to this stage, still I didn't do the thermal. I just put a lot of cold saline. And then after getting into the Schlemm's canal, you will see now that a good amount of percolation. And now I will go for those vessels. Definitely, we need to avoid any blood in the subconjunctival space, but you can see how much the percolation is great. And now I'm going for removal of the floor of the Schlemm's canal. So this is the trabecular meshwork and continuous with the descemet membrane anteriorly. This is called the trabeculo-descemet window, and this is percolating. So the whole secret in this operation is just to dissect a deep flap until I expose a good trabeculo-descemet window that will percolate the fluid, and the fluid will come to the subconjunctival space, and sometimes will go into the suprachoroidal space as well. So this is called non-penetrating glaucoma operation. And this is before I cut the deep flap. I just make sure, yes, I just cut the deep flap, and then you can see the fluid is percolating all the time. But the beauty of this, the anterior chamber is maintained. Nowadays, I close the conjunctiva with biothermy, and this is a published technique called sutureless deep sclerectomy, was published in the journal, Journal of Glaucoma a year ago. And then, again, we open the conjunctiva, corner space incision, and then we are dissecting the superficial flap. Do we put antimetabolites? Yes, we put antimetabolites exactly like trabeculectomy. And then again, here this is a good diaphragm, and then this is the superficial flap. And then here I am putting antimetabolites deep to the superficial flap. Then I will start cutting the deep flap. The point is that I need to be deep. Here the flap is a bit small. Yes, once I am deep, then I can see the end of the scleral spur. Again, it should be a sharp, continuous line, and then this means I am in the correct plane. And again, you will see the equus will start percolating, and I did not expose then still a good part of the trabecular meshwork, but the percolation is really good. So then we test the percolation, and then we cut this flap, this That's why it's called deep sclerectomy. And then I put the superficial flap back without sutures. And for the edges of the conjunctiva, sometimes I just do diathermy, and that's called the sutureless deep sclerectomy. And again, deep sclerectomy results in gradual decompression of the eye, and it's very helpful for patients with advanced damage and for the young patients extra. And then sometimes you get blood from the cut ends of Schlemm's canal, and then it's okay. You can see the percolation is fine. I'm content with the percolation, and then I put the tissue back, and that's all. Now, just a demo for you. This was one of the procedures that I published years ago. When you can see that when we cut the D flap here, the D flap is cut, and then these are the cut ends of a Schlemm's canal. It is just a demo for you, just to see that we can place Prolene suture inside the cut ends of a Schlemm's canal. And this is Prolene 5-0 or 6-0, and then I push it inside the Schlemm's canal in one side, and then it's a large segment. It's like 10 millimeters, and then I angulate, and then I can place it inside the other cut end of the Schlemm's canal. This technique is called Prolene canal stenting. It just helped me. I thought it will keep the Schlemm's canal more patent so that it can accommodate the aqueous coming from here to go into the cut ends of the Schlemm's canal. It's called Prolene canal stenting, and it is published a few years ago. The point is that you can get good access to Schlemm's canal here. Again, now, yes, I am getting inside Schlemm's canal, and then center your flap, and then I leave it. And then it helped me in another way. I'll show you like that. Then when we do gonioscopy, this is the suture inside the Schlemm's canal. So that when I need to do goniopuncture, when I need to just do a hole in the area of the surgery, I'm guided by these sutures. So it helped me at the time. Now for the beginners, just for the beginners, if you like to have more access to the Schlemm's canal, you can do like that. It's called the trabeculotome guided deep sclerectomy. I just published this like 15 years ago at the beginning of deep sclerectomy, because when I dissected the D flap, sometimes I open the Schlemm's canal, sometimes I open the antechamber. I am above the Schlemm's canal. So I decided to help myself by a technique which is known for the pediatric glaucoma surgeons when they expose the Schlemm's canal. And you can do that right now. You can just help yourself to better identify the Schlemm's canal. Then when we are inside the Schlemm's canal, and then you can introduce the trabeculotome. The pediatric glaucoma surgeons are so familiar with the trabeculotome. Now the trabeculotome is inside the Schlemm's canal, and then I will do another cut as an exit for the trabeculotome. So again, you can just train yourself to identify the location of the Schlemm's canal this way. Again, just doing another cut and then getting an exit, because this will keep the trabeculotome stable inside the Schlemm's canal as I'm doing right here. If I just leave it inside the Schlemm's canal, it will tear into the antechamber. And then I will do D flap dissection guided by the trabeculotome. Then I dissect the D flap, and now I'm very confident that I'm opening the posterior wall of the Schlemm's canal, because the whole secret of the operation is here, to open the posterior wall of the Schlemm's canal. That was at the beginning of my, and I think it still can be helpful for those who are interested to start deep sclerectomy. And then you can see the aqueous is just coming after the Schlemm's canal is open. So again, this is called the trabeculotome guided deep sclerectomy. I don't do it nowadays because I'm more trained to the position of the Schlemm's canal. It doesn't mean that all the operations are successful. No, I still can go above the Schlemm's canal or can open into the anterior chamber, but definitely with a small percentages. We can do deep sclerectomy for the children, but for the children, you will see great percolation. But again, we don't do deep sclerectomy only in children, because they are having a lot of scarring. So that, yes, imagine the percolation is great, but again, it won't solve the problem of glaucoma. We will go for trabeculotomy, as I might show at the end of the talk. Now, if the pressure goes up after deep sclerectomy, I do what's called the goniopuncture. I just put the patient on the slit lamp, and then I see the area, and then with the YAG, I do a hole in the surgical site. This will help will create a micro perforation. It's not a big perforation, just micro perforation. Again, if this doesn't work, again, this is an external filtering operation. I will take my patient to the OR, and then I will do needling. So again, it is an external filtering operation where the flap can get some scarring. So I might get some, you can do needling as well if needed. And this is a deep sclerosis, again, where the bleb is ischemic, but again, with a lot of scarring, because being ischemic doesn't guarantee it's properly functional. You can get scarring. You can elevate the conjunctiva with the lidocaine, and then you can inject also anti-metabolite diluted at the end of the operation. And then I will go to cut the boundary here between and the rest of the subconjunctival space to communicate this area. So again, it is just like trabeculectomy. So we're having a bleb and we need to needle this blood. So needling again is a procedure we perform for deep sclerosis if it is not properly functioning. And again, I can do a kind of perforation as well. Okay, so that if the needling doesn't work, then I can go for a kind of perforation as well. So we still can do that with deep sclerosis as well. Now, another option for deep sclerosis, we can go for revision. Now, this patient sclerosis a couple of years ago, then he presented with elevated ocular pressure and needling field. Goniopuncture didn't solve the problem. It was not obviously lowering the pressure. Now, what I'm doing nowadays is I'm opening the surgical site. So you can see that I'm opening the surgical site. Again, this is the area of where the deep flap was cut. What I will do right now is just elevate more of the tissue here and cut more and expose more of the trabecular meshwork. So we can still go for revision of deep sclerotomy. So again, this is after some work, the cut ends of Schlemm's canal, and the aqueous starts to percolate, and we put more anti-metabolites, and then we put everything back again. So there is a chance for revision of deep sclerotomy. So if the pressure goes up after deep sclerotomy, again, we need to exclude the steroid response. Then we go for goniopuncture. If the pressure goniopuncture, sometimes it doesn't solve the problem, we can go back to one medication. It's okay for the patient. If not, we can go for subconjunctival needling. If it solves the problem, okay. If not, I can go for revision of the surgical site, or I can go for another surgery. That could be deep sclerotomy. Usually, I tend not to repeat the same operation, so it can be a trabeculectomy, for example. So for the deep sclerotomy, then Dr. Islam, any questions for the deep sclerotomy before we proceed to the angle closure?
Yeah, we have two questions in the chat about the suturing of the external flap. Are you suturing it because he didn't notice it?
No, I don't. No, I don't.
Okay.
I don't. Yeah, I don't have to suture. The point is that I want this flap to be elevated, and sometimes I put healing because usually this is called a lake under the scleral flap, and you can put an implant, which are unfortunately not very available around us, so that you can put healing, and I put anti-metabolites to keep the superficial flap elevated so that I don't have to suture it actually. And I think the trend now is not to suture this flap unless you put an implant.
The other thing is size of the Prolene suture used for inside the canal. You said
it is 6.0 or 5.0, but 5.0 is stiff, so that you can hold it. It's actually giving you that sufficient strength, and so that you can place it inside the Schlemm's canal. It's 5.0. It's Prolene. The procedure, by the way, it's called Prolene canalostentin. It's published a few years ago. Prolene canalostentin.
Dr. Ahmed Yahya has a question. He raised his hand.
Yes.
Thank you very much, dear Professor. I have some question. Do you use implant or not in deep sclerectomy?
Unfortunately, we don't have it available around us. So that if I have it, I would go for it. But I try to compensate by the anti-metabolites, by the healing, and by leaving the flap without sutures.
Okay. When you go anteriorly, how you do separate the disseminated membrane from the deep scleral flap?
Yes, you can use something blunt. so that you can use iris repositor, for example, but not a pointed one, so that it's something blunt. So yes, you can go in this space with there is a special instrument for that, a special instrument with a rounded plate, but you can't do it with anything that's blunt.
Yes, as you said in the previous lecture that you don't do a combined phaco and trap. Do you use, do you do a combined phaco and deep sclerectomy?
Yes, a lot, Dr. Ahmed, a lot. Because if the patient is having open angle glaucoma, I'm actually quite confident that the phacoemulsification doesn't reduce the pressure significantly in patients with open angle glaucoma. And the results in the literature are very conflicting, starting from 1 to 2 millimeter to 3 to 4 millimeter, but sometimes 3 to 4 millimeter are not sufficient for the patient. If the patient is presenting with a pressure of 30 and lots of medications, so that 3 to 4 centimeter will not help on the long term. So that I like to add deep sclerectomy in a case of open angle glaucoma. The only situation if the patient is having a very mild disease and using one medication, and I have to inform the patient that I might not stop the medication and we might go back to the single medication.
I have two questions. In case of juvenile glaucoma, would you prefer trabeculotomy or deep sclerectomy? This is the first question. And the second question, can you do, in case of failure of deep sclerectomy, can we use the same site, the same scleral flap to convert it to a trabeculectomy, for example?
Dr. Ramona, thank you very much. Now, when you operate for the young, and actually juvenile open angle glaucoma starts from the age of 3 years up to the age of 40 years. So that this is where the juvenile open angle glaucoma. So that if the patient, like in the, for example, like the patient is 2, 3, 4, 5 years, so that the patient, I mean, is a child, so that I added trabeculotomy to the deep sclerectomy. But if the patient has grown, so that the patient is now 20, 25, 30, 35, I only do deep sclerectomy. But if there is anything that prevents from adding trabeculotomy, no. And I think that's a quite interesting point for research, is to add the trabeculotomy in the relatively older age group. Yes, so that it's still an option, but I really don't have a good opinion about the results. But I just go for deep sclerectomy. But if they are young enough, then I add the trabeculotomy. Now, if you do deep sclerectomy and then you elevated the D flap, and then you are not confident with the percolation. Is that your question?
My question is, in case of failure, you said in case of failure of deep sclerectomy after trial of revision, if I didn't manage to do a successful revision, or it failed again, can I use the same site for a trabeculectomy, or I have to go to another site?
I would recommend to go to another site, so that if you decided to do a trabeculectomy, another surgery, so that when you just evaluate your patient that is having a lot of scarring, then you don't want to play with this area again. So that I don't recommend to open the surgical site for deep sclerectomy to do trabeculectomy. It's not easy to do that. I just would recommend that you go to another site for trabeculectomy. But again, before you do that, I would love if you just inject saline under the conjunctiva and make sure that the conjunctiva could be easily elevated, because you might change the whole story.
Okay, thank you.
Thank you. Yes, and I see the article, the URL of the article by Dr. Dina here. Yes.
Dr. Muhammad Al-Ashri has a question.
Yes, please.
السلام عليكم.
اهلا دكتور محمد. عليكم السلام. راجل الجميل.
شكرا جزيلا، والله حاجه ممتعه جدا، يعني الواحد لو سمع المحاضره 1000 مره دايما بنستفيد، يعني شكرا جزيلا لحضرتك.
ربنا يخليك، انت انسان رائع والله، من اجمل الناس عطاء وعلما. ثانك يو فيري ماتش دكتور محمد.
ربنا يخليك يا استاذنا يا رب، ربنا يخليك. بعد اذن حضرتك السؤال الاول، احنا حضرتك دايما تفضل ان احنا نعمل كاتراكت وديب سكلكتومي، ولا لو الحاله الكاتراكت مش انديكيتد او يعني مش سيجنيفيكانت؟ فده اول سؤال. حضرتك دايما بنعمل كومبايند، ولا حضرتك ما بتفضلش كده، او يعني حضرتك بتعمل ايه في
شكرا دكتور محمد. ثانك يو فيري ماتش فور ذيس كويستشن.
السؤال الاول. في سؤال ثاني بعد اذن حضرتك يعني.
طب هجاوب على ده الاول يا محمد so as not
تمام.
to forget. Now for the open angle glaucoma we don't remove the lens unless the lens is cataracted. The only situation in which we may like to remove the lens while the lens will still not cataracted is pseudo-exfoliation, because there are so many reports that it adds to the control of the intraocular pressure. But for regular open angle glaucoma, we don't remove the lens unless it is cataracted. But if the patient is having glaucoma, we focus on the glaucoma.
عظيم. السؤال الثاني، الميتابولايتس حضرتك دايما بتستخدمها ولا مش دايما؟
I use metabolites in anti-metabolites in 100% of patients. I'm sorry, not in 100%, but I mean in the majority of patients. Few exceptions are very old patients with very atrophic conjunctiva, so that the conjunctiva thinned out. And sometimes I'm so hesitant in the myopic patients. Otherwise, I use anti-metabolites. I use the anti-metabolites as a sponge, and then I switch it for a while to the subconjunctival or subtenon injection, and then I'm back to the use of sponges because I feel they can go as posterior and homogeneously as far I want them to go. So that nowadays I prefer actually the sponge, the classic way of anti-metabolite application.
تمام. شكرا جزيلا يا استاذ، شكرا جزيلا.
Thank you very much Mr. Mohammed. Thank you.
دكتور احمد معلش بقى السؤال مننا بس عشان for the audience also. First thing is how to define the Schlem's canal, because they have to know how we can define the Schlem's canal. So you said about the reflux of blood, and second thing, I think
the reflux of blood after being opened. But the point is, you need to know where Schlem's canal is to open in the first place, and then you can know after being opened, this is Schlem's canal. Before being opened, I think you need to be deep in your dissection so that you can see the blue color of the ciliary body, and then you need to see the scleral spur. This is the end of the sclera, a sharp line, white line, because at the scleral spur, the fibers of the sclera are transformed into transverse fibers, so that you will see that end of the sclera, and then immediately after that, you are in the Schlem's canal. And actually, Schlem's canal is a space lined by the endothelium, so that once you open this space, there is no tube that you cut. No, it's mostly an endothelium space lined by the endothelium. So you just get to the deep, and then you open the posterior wall of the Schlem's canal. And then you are inside the Schlem's canal. But again, the landmark is the scleral spur. Then after you open the Schlem's canal with hypoton, with decompression, then you can get some blood coming from the Schlem's canal, because there are some blood vessels inside Schlem's canal in the majority of the persons. But for that reason, Dr. Islam, I know that when it is difficult at the beginning, that I opt to put the trabeculotomy inside the Schlem's canal, so that now I know I'm inside the Schlem's canal, and I start dissecting the D flap, and then I know that at the end I will just cut on the trabeculotomy and I'm inside the Schlem's canal. So it was a landmark in my thinking to get to the Schlem's canal is the trabeculotomy guided surgery. But afterwards, I don't need it, because I just get used to the depth of the sclera that I need to dissect. But for the beginners, it might be a good idea for them to just place the trabeculotomy inside the Schlem's canal, and to see if that's going to help them. It helped me at the beginning, like 15 years ago.
Yeah, because for us who are doing the risk camelostomy, we have the Grishaber cannula. And the Grishaba cannula is nearly same the idea like the trabeculotomy, but very fine. So we can just, if you put it inside the canal, and you can get side-to-side movement after opening it. The question I asked
sure.
because of you know, when you said that it is a ciliary body. This is, I want to clarify for the audience to know the difference between the Schlemm's canal and the ciliary body, not to complete the dissection over the ciliary body too much. This is my aim, my main aim.
Right. You're absolutely right, Dr. Islam. You're absolutely right. Because if you just think that you are you will just enter the ciliary body. Okay? But the point is that, yes, you can see yes, you know that you are leaving a very thin layer of sclera. But this is not a guarantee that you will go in this microns all the time with that very, very smoothly until you open the Schlemm's canal. Sometimes you cut through this micron so that you will see the ciliary body. The point is, when you see this ciliary body, then you think this is the scleral spur, but scleral spur is not a point. Scleral spur is a line, is a sharp horizontal line. So when you see a dark point, just point at a level. Now, probably you have cut through the sclera, this is the ciliary body. Just go upwards. Nothing will happen. Just go upwards. Yes, but you are absolutely right. We need to identify. We need to identify this is the ciliary body.
Yeah. The other thing that for as we talk about non-penetrating glaucoma surgery, you said you are not taking sutures in the superficial flap as deep sclerectomy, but for viscoelasticity, we have to take tight sutures and inject the viscoelastic in the scleral leg. But this will make the blip, as you talk about, because you know, for non-penetrating glaucoma surgery, suppose there is no blip or minimal blip. But if we are leaving the flap without suture, this is what makes the blip.
The point is that, yes, I have a rationale, of course, for that, because for deep sclerectomy, it is it's a low filtering operation. It's not like trabeculectomy.
Yeah,
because there is an equal circulating, but it is a low flow system. So at that time, when you just attach the edges of the conjunctiva with the fibrin of the diathermy, and then now you have two forces opposing each other, the low flow equus and then the attached edges of the conjunctiva. And I think the force of the diathermy is stronger than the force of the equus. But telling you the truth, sometimes the conjunctiva retracts a little, yes, for that. But actually, the hypothesis is that the edges within few hours will be strongly adherent and then will prevent retraction. But if you are going for deep sclerectomy, and again, if you see a lot of circulation, and then if you see that there is a lot of equus coming out, then there is no meaning in leaving everything sutureless. This is not okay. You need to suture, of course. So that if you got a microperforation of the trabecular descendants membrane, you need to suture. If you put helium, if you decided to flood the whole area with helium, there is no meaning to make it sutureless. Okay, I mean that when you see a lot of things in deep to the conjunctiva, you need to suture the edges of the conjunctiva.
Yeah, as you mentioned, the microperforation or macroperforation, I think the idea for those who are starting to do non-penetrating glaucoma surgery, if you have any microperforation and you are not sure that you sutures well, I think it's better to leave it on air, because if you didn't leave it on air, even a minimal small bubble, and it is not to fill the whole EC, because sometimes you can get an iris carceration in this microperforation and it will elicit adhesions at the site you did. What do you think, Dr. Ahmed?
Yes, you're absolutely. Look, for the deep sclerectomy, the idea is for non-penetrating, but sometimes it doesn't end in being completely non-penetrating. You are having a microperforation, but for the microperforation to happen, it must be in the area of the trabecular meshwork. It has to be in a relatively tough area. You can get a microperforation. If you get a microperforation, what will happen? You will get a lot of equus, but at the same time, the pupil is rounded, so that there is no iris coming out through the defect. Now, this is a microperforation, so yes, you can inject air inside the anterior chamber to do a kind of tamponade. But what will happen is that the whole membrane ruptures, and it usually ruptures at the weakest point, which is the junction between the trabecular meshwork and the descendants membrane. And this is called the Schwalb's line angonioscopy. And this is the weakest. If you see this junction, beware of that, because this is the area when it ruptures in the whole area will rupture. It's not just a small defect. So that once you see the trabecular meshwork is ending and the descemet membrane is starting, the trabecular meshwork is a shaggy structure. Descemet membrane is a very translucent. So the junction, beware of these junction and don't play too much around this area, because you can get macroperforation. Now, if it happens to get macroperforation, what will happen? Automatically, you will get the iris. And actually, the iris doesn't come in a small. No. Usually, you will get huge prolapse of the iris. And at that time, you just have to do iridectomy and then reposit everything. And now your operation is converted to trabeculectomy, and then you have to suture everything. The good news about that when they compare patients who just underwent classic trabeculectomy and those who had complication of macroperforation, actually there is no significant difference in the major complications in the post-operative period. So it is still manageable. And with that, I just convey to you good news is that if you are doing your trap on an open angle glaucoma, and then you can start with deep sclerectomy. And then if it happens that the deep sclerectomy is converted to trabeculectomy, then you have nothing to do.
You didn't lose anything here.
Yes, that's the situation. Just a good iridectomy and make sure, as you have said, there is no iris.
To encourage everyone at the end, you can do the trap if you didn't succeed to complete as the deep sclerectomy with viscoelastic.
Yeah, for sure. So deep sclerectomy is very forgiving, so that if it's not performed at your best, you can still convert to trap. There is no problem with that. But again, with time, when you just get trained to the identification of the Schlemm's canal, and then you will love the sclerectomy. And actually, it's much safer, but it needs a lot of work in the post-operative period as well. So for Islam, I just wanted to move to the rest of the talk.
Sorry, yes.
So for the angle closure glaucoma, I just have mentioned again, with the angle closure glaucoma, we need to remove the lens. And that's the management for angle closure glaucoma. Please remove the lens. Whether the lens is clear or not, it makes no difference. You need to remove these bulky lenses from the eye. And the cataract surgery is not easy because it's a hyperopic eye with short eye with the shallow anterior chamber. So it's not an easy operation. It's not a piece of cake cataract actually. And then after you remove the lens, if you have areas of the angle that's occluded with peripheral anterior synechial, I usually go with the spatula. I use my lens, and then I go and open the angle anatomically. I like to do that in the process of the synechiolisis. I just repeat it as much as I can, and sometimes I use the aspiration and I inject a lot of air because I'm quite sure that the air will push the iris back and open the angle. I keep injecting air at the end of the operation, and actually, whatever the degree of damage from the angle closure glaucoma, you don't have to add trabeculectomy. I stopped adding trabeculectomy at all because I just saw complications from the trap, malignant glaucoma scarring. So that if I just concluded my surgery and then the patient needed few medications, it's okay. If the patient needed glaucoma surgery, then glaucoma surgery could be performed under very favorable situation. But to add the trabeculectomy to phaco in angle closure glaucoma, you will invite troubles. And this is my experience along years. That's why I stopped doing trab. I just do phaco. Phacogonal synechiolisis is my preferred operation, and then I evaluate the situation. So this is the patient, for example, she underwent a trap. Okay? She had chronic angle closure glaucoma. She underwent a trap. And what happened? She developed galloping cataract. And then the cataract surgery, I had to do the cataract surgery in 2 weeks. And you can see that everything is bad. The Argentinian flat sign, and then you cannot see properly to manage again. It's not a piece of cake. It's not an easy situation. And then I have to remove the epithelium to be able to see something. You are not very confident what is the position of the intraocular lens. So again, it is just to do trap. The point is that the anterior chamber and angle closure glaucoma is sometimes very shallow, and it does not tolerate further shallowing. So if you start with trap, okay, then you get a kind of overfiltration, then expect the troubles with loss of the anterior chamber, endothelial affection, malignant glaucoma. So that Now I don't do trap. I stopped doing trap. It is just phaco. So it is just a case. What happened to manage this again with the Rexus? It's a very bad Rexus, as you can see. So that, do you have any different opinion, Dr. Islam? Please, I would love to hear from you.
For angle closure glaucoma, I agree totally with you, Dr. Ahmed. This is mainly a case of lens problem. So you have to remove the cataract at the beginning and do syneculisis or angle sweeping. Sometimes you can use the Kahook if you can use it. Can add some benefits, but at the end it is a cataract surgery mainly. And by the way, you know, some machines like the AL scan, it has the sham flow camera, so you can just do the sham flow camera, take a picture for the eye before the surgery. You will know it's like UPM or OCT anterior segment, but in the IOL machine, in the biometry machine. So it is very nice to get an idea about the angle and how much you need to interfere inside the surgery.
Interesting. And you can simply do gonioscopy.
Yeah, of course.
You can simply do gonioscopy. You know, I like your expression. It's a lens problem. I like very much your expression. It's a lens problem. Yes, it is. Yes. So that any of the participants has a different opinion, would like to ask something?
Yeah, Dr. Ahmed Yahya again. Yes.
Yes.
Dear professor, if you have a chronic angle closure glaucoma after you completing the phaco, and if you have no agoniolens, can you do blindly or by OVD?
And I think you can do. And what's really more helpful is to inject the air repeatedly, because I think that can do something. And then if you use the aspiration port close to the iris suit, you try to just get most of the iris, and I think you still can do something. You still can do. Definitely, it's a blind procedure. I'm not quite sure what we're going to do, but it might help.
Thank you very much.
Dr. Islam, shall I proceed?
Yeah, you can proceed.
So that for valve surgery, and actually, I'm not a big fan of the valve. I'm not a big fan of the valve, but then actually, when you think that what are the situations that you will think of the valve? And actually, for an eye that is so much disorganized, if you have a very much complicated cataract surgery and the cornea is not good, and so that I usually don't think of a valve. Probably the situation which I think of a valve is either a pseudophakic eye, especially if a failed glaucoma surgery and a quiet eye, so I might think of that. Neovascular glaucoma after regression of the new vessels, that's a good option as well. But generally, the valves I think they need a quiet eye, because if the eye is a bit disorganized, you can go for diode. But I'm having just few comments on the valve. Now this patient is pseudophakic and the lens is decentered as we see, and the pressure is having glaucoma, and then I decided to put a valve. Why? Because I will adjust the intraocular lens at the same time. So this is one of the options. So I like to actually put some mark when I have some guys, because the eye sometimes rotates under anesthesia. So I want to know where is the 12 o'clock position. And this was the left eye. So this is the 12 o'clock position, and this is the temporal end. And I know my valve would be here. So I like just to put marks, and I like to use the, here I'm spreading the conjunctiva, and I'm also marking the areas where I put the sutures, and I'm placing 5 oedaclin sutures, non-absorbable sutures, so that I put the 2 sutures in the valve and the priming of the valve. You all know those steps. And then I'm putting the sutures even before I'm placing the implant. It's FD7. And then pushing The valve should go comfortable, okay? So that, yes, it's coming out, but again, when you push it, it should go comfortable. If not, you need to go with the more dissection, and then this distance should be a minimum of 8 millimeters, a minimum of 8 millimeters. If it is 10, that would be fine. And then I have secured the body right now, and I'm just measuring. It's like 10 millimeters. And then I'm just marking the place where I'm going to place the tube as well. It should be centered. And then I do scleral flap. I know there are many techniques for that. So that you can cover with cardium, you can cover with a sclera, you can cover with a lot of things. And actually, I like to do a 6 scleral flap, coverage, if the sclera can allow for that. And then cutting the tube. And sometimes we do another cut, and then doing paracentesis, because and here I wanted to adjust this intraocular lens. I just wanted to make sure that the lens will be adjusted and will remain stable in the new position. I'm just playing with the lens, and again, I'll put this lens horizontally. It might be an exchange with another type of lens if I did not achieve my goal. But again, at the end, the lens was stable. And then I will go with the 23 gauge needle. It is just at the immediately below the junction, behind the junction of the cornea and the sclera. And I go parallel. That is just parallel to the iris. Just parallel to the iris, yeah. Sometimes it's not easy to get the tube through this hole, but again, it's quite good to hold the tube this way. It gives you a good control, and then you push it inside, and then you need to see a good length inside the anterior chamber. Yes, and then I will suture this scleral flap, and sometimes I put further suture around the tube here, and this is the conclusion of the surgery. In this patient, yes, you might add the scleral flap if you think you need, but in this patient, I didn't need this. Then let us go for another type of valve that we have it in the Egyptian market is the Orolap. It is like Barvelt. It is the Indian Barvelt, actually. It's a large plate that but it's soft, so that you put it below the muscles, below the superior and medial recti. And then if it just goes below the muscles, then everything is fine. And then it has 2 holes as well, and then you need to secure it. But the point is that valve, it's a non-valved implant, so that there is no control to the flow from the eye until there is a capsule around it. So that we put 2 sutures of absorbable Vicryl. I put 2 sutures actually, and I make sure that the tube is really occluded, because if you are not tight enough, it will work. And then again using 23 gauge needle, and then placing the tube, and here putting air, and this is the conclusion of the cell. But again, you need to tighten to occlude the tube, and you allow the patient to be on full medical treatment for the early post-op until there is a good capsule around the place, and then you need to evaluate things afterwards. So it is just, now this is a patient which underwent one eye surgery. It's actually a developmental glaucoma, and then previous surgery failed, and then he had this Orolap, and it's really beautifully functioning. And that was the time of the second eye. I'm just testing how the first eye looks like. So just for the valves, we need to have sufficient indication, and then we need to have sufficient distance from the limbus, for at least 8 millimeters behind the limbus, and then you should have sufficient coverage to the tube, whether by the sclera, or you have artificial, or you have a preserved sclera, or you have a pericardium, or you have a corneal tissue, whatever like. But you should have sufficient coverage. Then you should have sufficient length of the tube inside the eye. It shouldn't be too short, because actually short tubes might retract, especially in children. And then you should have sufficient distance from the cornea. If the if the needle is introduced inside the anterior chamber and then you find the tube is directed towards the cornea, this is not good. Then you have to redirect this. You should have the tube sufficiently away from the cornea. So it is just for me 5 sufficient indication, sufficient distance from the limbus, sufficient tube coverage, sufficient length of the tube inside the eye, and sufficient distance from the cornea. So we can have a discussion if you want around the valves. Again, I'm not a big fan of the valves, but I do them very infrequently. So Dr. Islam, what do you think?
Me also, I'm not a big fan of the valve at all, yeah. But we do it at the times that nothing will be beneficial for the patient except the valve. So you have to do it when you have to do it only.
دكتورة مؤمنة رفع ايديها I think.
Yeah.
Yes.
تفضلي دكتورة.
I was asking about cases of silicon-induced glaucoma. Don't you think a valve is a good option in those patients? I have from my personal experience in the Demirtaş Hospital, we did like 10 or 12 patients. All of them had silicon-induced glaucoma. Their IOBs was like 30s on full medications, and their count was not that forgiving for a trabeculectomy or any conjunctiva based surgery. I mean, it's working well in them.
Where do you place them, Dr. Mu'mina? In the inferior temporal quadrant, or where do you place the valve?
I placed some of them in inferior nasal actually, and none of them
inferior
had.
Nasal, yes.
Yes, it was a little bit difficult, tight. It's a little bit narrow, but none.
Yes.
Yes, but the first patient I did was now 2 years ago, and up till now I had no one complaining of diplopia or muscle-related symptoms in this inferior nasal position. And 2 of the patients I think were in as the superior temporal, and it also worked well. None of them had the I did all of them post silicon removal except one of them. He had silicon in his eyes, because his retina keep detached after removing silicon. He had some silicon aggression from the valve, but it didn't affect his retinal state or his IOP.
Did you get any serious complication from the like hemorrhage, choroidal hemorrhage? Did you get any serious complication from the valve?
Serious complication only in one case, but it was more a technical error rather than related to the valve itself, because the patient, there was some sort of miscommunication with the patient and in his follow-up, and he didn't use the anti-glaucoma treatment in the early post-operative period. So he had very high IOP, which affected his cornea, which was already decompensated from the multiple retinal surgeries. This guy underwent retinal surgery 3 times. This is the only serious complication I had. And the other one, but it wasn't that serious. One of the patients had the constant exposure over the tube and hypotony. I replaced the valve. I transferred it from the inferior nasal quadrant to the superior temporal quadrant. And while doing this, I discovered that there was a huge tear. Almost the tube is separated from the plate. That was the cause of the leak and the constant conjunctival leak. So I replaced another tube in the superior temporal quadrant, and the patient is doing well now. Just the serious complications I had.
Yes. At the time of the surgery, do you place anterior chamber maintainer, or do you put heron in the anterior chamber, or how do you at the time of opening the eye? Then how do you manage?
I use missile at the time of eye entry and wash it
seems like
at the end of the surgery. Yeah,
What is your,
because they have their eyes. I've tried once in one of them to do it without this step, and it wasn't that easy at all to introduce the tube in the EC.
Sure.
Their
That's a very
fluid-filled
serious.
eyes, and their yeah.
That's the major disadvantage actually when you open an eye that's fluid filled. But you know, it will be a much more complicated situation if the patient is aphakic as well. And here that will be a bigger problem. And actually, I'm so skeptical in opening an eye that's aphakic and vitrectomized, because then actually, yes, you can succeed, but again, you will go through a very hard way. Thank you for sharing the experience, Dr. Mohammed. This is really interesting. Thank you very much.
Thank you.
Dr. Ahmed Khalaf.
Assalamu alaikum. Very much thanks for your effort and time. You're always surprising us. كنت حضرتك على what's your opinion about retropalpar diversion of aqueous humor. كان في برضو في احد السيمينارز كان اللي هي pretty conventional شويه في يعني
rec tube.
بالظبط.
Rec tube, yes. Yeah, you know that we had a nice lecture about that from the Rec himself, and you know that was really interesting. I'm not quite sure if that tube is available in the market or not. I really don't know if it's available commercially, because he has the patency. I know that he has the patency right now, but is it now commercialized and available in the market? I don't think so. I don't think it is. In this, I just got the impression it is just in the phase of testing more and more to get more data. But you know that it's a kind of it's a valve which is you know that without an actual valve mechanism, but it's okay. It's very attractive, of course.
Yeah, and actually, like, it's pretty. Actually, I have also very slow, not slow, actually, a pretty fast learning curve, and the idea of like moving the aqueous humor to the retropalpar space, it's also pretty questionable if it leads towards like further complication or not. Yeah.
Yes. You're absolutely. You know that a friend from the States just asked what about the you know that how the compartmentalization will be, and it's a bit, but the idea itself is really attractive. Yes, but the point is that when we operate on eyes with a post-vitrectomy, and then you can see that sometimes we are having more than one problem in placing the valve. Sometimes the conjunctiva is at fault. Sometimes they are having like a buckle around the eye, so that it is not always easy to put an implant. But and actually for those eyes, I just go straight ahead for cycloablation, and I feel completely comfortable with those eyes with this treatment.
Okay, thank you.
Thank you, Ahmed. Thank you, Ahmed. Thank you very much. So, Dr. Islam, shall I continue?
Yes, Dr. Ahmed.
Yeah, so that, and I think the cycloablation, you have heard a lot about cycloablation, Dr. Islam. I think I give more than a talk about that. With the painful blind eye, it's a very acceptable option, of course. And then, you know that it's indicated basically in refractory glaucoma. And refractory glaucoma in means of refractory in relation to trabeculectomy. So that if trabeculectomy is likely to fail, like a patient who is neovascular or uveitic, or following vitrectomy, or trabeculectomy have already failed, or trabeculectomy is not feasible, like is a patient having scarred conjunctiva, so still trabeculectomy is not feasible. So that all those situations called refractory glaucomas, there is a good place for the cycloablation. But in this patient, for example, who is a pseudophakic with a hard lens, really that I can't see even where are the haptics of the intraocular lens. But the point that is a young male, is a 35-year-old presenting with pressure of 50 under full treatment. So that, you know, that I think a lot before opening this eye. Yes, I might think of opening this eye and, of course, readjusting the position of the lens. It might be too much for this eye. So they just went for diode cycloablation, and the pressure is really beautiful. And the operation has been done like 4 months ago, and the patient is fine so far. I might repeat, of course. A patient who is non-ophthalmic, sometimes a good option, and you can see good indications here. A patient who had previous vitrectomy and anti-chamber lens. It's not easy to do anything else. Patient post-keratoplasty with a very shallow anterior chamber and aphakic. Again, it's not easy to even put an implant. A patient with a pseudophakic and graft in the cornea is not very friendly. Again, putting a valve will be too much load on the graft itself, so that you have to think what to do actually. A patient with completely plastered conjunctiva, where you cannot elevate the conjunctiva. There is no way to do penetrating or non-penetrating or a valve, nothing. You can't do anything except going for cycloablation. So cycloablation has good grounds. For example, this one-eyed patient with anterior chamber lens and sutured iris. Again, he was referred with a pressure of 40, and the disc was advancedly damaged, was very bad disc. So that again, to think to open this eye so that you can see that again with CD 0.9, so that you can imagine how much the visual field will be bad to open this eye. So again, just go for diode. I keep the eye closed and then I do diode, and then I can repeat diode if needed. Again, a young male with vitrectomy, one eye, this is the other eye. Again, the pressure was in the 40s after vitrectomy. So again, I don't like to open this eye. Affect vitrectomized eye. I don't like to open those eyes. Those are bombs, so that I like to keep those eyes closed, and then I manage them as needed. So I did just micropulse, and the patient is fine so far. So with the indications of the refractory glaucomas, recurrent after glaucoma after a valve, sometimes there is some push for primary glaucomas, but with other types of lasers, as we will see, also in eyes with good visual acuity. Hypotony is not too much, but especially with the new vascular glaucoma. And these are the technologies we have: the transscleral diode, the endoscopic, the micropulse, the high intensity focused ultrasound. So these are and this is my set actually. I have the continuous wave diode, I have the ultrasound, I have the micropulse, I have everything, because sometimes we need those technologies. What we can do like that is, it is just sorry, the video is not here. So what I'm doing right now, just to help myself, if this is the cornea, I like to put marks, to use the corneal marker. The corneal marker used for before keratoplasty, it has 16 blades, so that when you stain those 16 blades, and then you can just put on the cornea, then you will have two horizontals, which I like to avoid because the long ciliars are here. And then I have 6 blades superiorly, and then I have 6 blades inferiorly. And then you can apply your shots, one on the blade and then one in between. And sometimes I do that, I apply 2 shots behind each other with 1 millimeter difference, so as to do extensive treatment of the ciliary body. I start to see good results from that. So that I'm just marking the cornea before I start therapy. And I'm so happy with that technique, which I think it's helping me too much. And actually, no reports in the literature, I just thought of it, and I hope to publish it. So again, I have this, and then I will go with the 24. I have 6, so 6 by 2. I have 12 applications up and 12 applications down, and then I spare the 2 here. So I'm quite sure that I left the horizontal meridian. So that's what I'm doing nowadays with the cycloablation actually. So when we move to the micropulse is, that I know that some of you might have tried the micropulse and they got frustrated from the results. The technology is evolving with the micropulse, and they are trying to improve it because they call it ciliary body MIGS, and actually MIGS. And as you have heard, definitely that it depends on massaging the superior and inferior limbus. So the whole technology is like that. And again, it is 80 seconds for the superior half and 80 seconds for the inferior half. And it's a treatment of 31% of the cycle. So it's a micropulse. There is a good time for relaxation. And again, this is, you can increase the time up to 90 seconds. Okay. And then this is a patient which is actually has a previous implant and previous vitrectomy, one-eyed patient who is 32-year-old male. And actually, he came with pressure in 40s. And then I tried to do some needling for this then, and it didn't work. And then I put a management plan for these patients that we will go with micropulse first, and then it might be a developmental glaucoma because you can see a broad lens, because I think he had a developmental glaucoma which is a bit becoming more aggressive, and he developed complications like retinal detachment and so forth. So now I did him micropulse, and then I retreated him again. I'll tell you what I did for him. And then this is the recent probe. Just the company, the Iridex, just coming out with this probe a few months ago, and they think it's better for application. Nowadays, we have some good results in the children as well. High intensity sound. The point is that they realize that the ultrasound can't read the ciliary body, and actually it is not the ultrasound for phaco, it is high intensity focused on the ciliary body, and this is the SEC. We have and this is again an eye, a pseudophakic eye with previous field glaucoma surgery. There is a suction cup which applies a suction of a vacuum of 70 millimeters, and then you just activate with the foot switch, and then there are different sizes for every eye. There are some parameters you need to submit, and then you put a lot of fluid actually for the cooling, and then after that you will fit the transducer, and then you can see this procedure because the transducer, it's a kind of they have 6 pieces ceramic crystals, and you can see it on the machine while treating the 6
continue.
crystals here. So they are activated one after the other. It works for seconds, and then there is a relaxation time for 20 seconds before moving to the second crystal. And in total, it treats like 45% of the ciliary body. That's quite interesting that it treats only 45% of the ciliary body. Some good clinical outcomes. We have reported some good clinical outcomes as well. The problem with the high intensity focused ultrasound is the cost, and actually the set is a disposable set for every patient, so it's a bit costly, but anyhow it's good to have it in some patients. The cycloablation, definitely they are having a wide range of indication and being rapid extraocular procedure and an outpatient procedure as well, because we train the residents to do that. Repeatable, cost effective, if not using something expensive, and titratable, so that you can treat 270 and then 80 and then 180. So you still have the chance to titrate. You don't have to treat 360 all the time. The disadvantage, some vision threatening complications are possible. Repeat is sometimes a problem, the cost is sometimes a problem, and there is no sufficient data for the epithelium. What I actually do nowadays also is sometimes I combine more than one technology, so that I start with the micropulse, and then if the outcome is not satisfactory, so that there is a pressure reduction but still not satisfactory, then I can do continuous wave, but again, not extensive. So that if I start with the micropulse with the pressure of, say, it was 35, and then the pressure is like 28, or the pressure is 30, now I can do 180 treatment with continuous wave, so that when I pre-treat the eye with a micropulse, this actually helped me in some patients to use less energy continuous wave to achieve a beautiful intraocular pressure. So that sometimes I combine more than one technology. So that's just a glimpse about the cycloablation. I don't know, Dr. Islam, if you have comments on that.
The same comment for the, especially the micropulse is really an expensive, especially if you don't have a lot of patients. If you have working in just in a private or
Sure.
not collecting patient, because the problem is that the time factor. The probe is only for 90 minutes for the Iridex, and the Quantil now they said it is 2 hours, but in a matter of six hours. This is the idea. And also it is, as you said, sometimes it's like frustrating because the result is not that good. Even I brought the company representatives, and I told them this. They told me there is a trick in that you have to use a viscoadaptive material on the cornea, on the sclera, so it will deliver the diode better than doing it on an bare sclera. So At the end, it is for mild to moderate. It is not for severe glaucoma. It's still the CBC, the regular CBC, is the standard for severe glaucoma. Even before I did it for seeing eyes, and we still, alhamdulillah, it was preserved vision. But I am not really encouraging to do it on a seeing eye for the regular CBC.
The continuous wave.
Yes, the continuous wave. Yeah.
Yes, yes, I totally agree with you. I totally agree with you. There is no meaning to do on a primary glaucoma continuous wave CBC. That's the point. But if the patient had like seeing eye, but had previous failed surgery or had something else, so that now you can go for it. But for a fresh eye, that you have a lot of options, so that you will never go for continuous wave, but you may go for a micropulse, high intensity focus. I really don't know. But again, I totally agree with you that it's not on the priority of the list to go with continuous wave. Definitely, yes.
We have Dr. Ahmed.
No, you know, Dr. Islam,
yes.
I just have heard something beautiful, that if you have done your patients, and that's a new indication for micropulse. If, for example, I did my patient deep sclerectomy, okay, and now the pressure is 25, so that I wanted some more effect, okay, so that at that time you might think of a different technology like micropulse or something like that. So if you want to augment something you have already done, I think that's a beautiful indicator. If you have done a valve and then the pressure is like 23, 24, and you see it's high for this patient, then you can go for a micropulse. And this seems like a decent indication, because what happens is that when we have a recent technology like micropulse, we start to apply this technology on patients with pressure of 60 and 50. And actually this technology is not for those patients. And then we feel frustrated, but then actually it was a wrong indication from the beginning.
You know what I am doing? Just sometimes if I need an augmentation, I can just use SLT. And I used it many times, yeah. And during doing the YAG goniopuncture, I have the ELIX, the SLT, and YAG gonio. So at the same time, I can just complete some part of the SLT and do the goniopuncture, and it gives a good result, by the way.
Yes, interesting. Yes, the beauty when you have a lot of technologies around you, then you can maximize the service you are giving to the patient. Definitely, yeah, sure.
We have Dr. Ahmed Khalaf. You want to ask?
Ahmed, yes, please.
So, Dr. Ahmed, we just want to add something, because, like, you know, when in my residency, I learned all of the psychophysiologization only blind eyes. But when I started working in another hospital and I saw the consultant already doing it for a patient with 0.1, I started to search, and actually I found some papers saying that even it can be done in poor vision or poor prognosis for the vision, but not only for blind patients. So that also some comment that, because it's always said that's only for blind patients.
Yes, absolutely. You are absolutely right. Yes. Yes. You know, the point, Ahmed, when you apply a laser for an eye, for example, with advanced damage, sometimes I do paracentesis for those eyes, because after treating the ciliary body, you are having a spike of intraocular pressure, and definitely that could be so harmful for patients, for example, with advanced damage, and then you wanted to do diode, but then it's better. I feel more relaxed when I do paracentesis, just to get the pressure lower immediately after the operation.
Okay, thank you.
Thank you. Dr. Islam, I wanted to show something for the kids. I know that, yes. Is there any question before I just present this?
You can.
It is just very short. For the pediatric glaucoma, I used to do deep sclerectomy, trabeculotomy, like here. So that, and I think some of you, and it's popular really in Saudi Arabia, actually. I think that technique, whether to combine the trabeculotomy with deep sclerectomy or with trabeculectomy, there is some company. This is the conclusion of the surgery. And then what's growing now is the concept of circumferential angle surgery. And at that time, we have this illuminated catheter. And then it's not available anymore in the Egyptian market, but it was really great, because you need to have you know, that the catheter illuminated until it comes here, and then you need to just see everything until you get both ends from the wound. And then when you apply traction on now the catheter is inside the Schlemm's canal, when you apply the tension gradually, you will tear definitely the Schlemm's canal circumferentially. So this is the idea of the circumferential angle surgery is really growing, and the GAT operation is one of those. I'm actually trying to do GAT. It's not an easy, but just training myself because I like the technique. And now again, you can see how much the tearing through the Schlemm's canal. And then I just wanted to show you this because it is a very economic circumferential surgery, but again, it's not always possible. And then what we do, and actually we expose the Schlemm's canal the way we are doing the deep sclerectomy. And again, I'm just putting the trabeculotomy inside the Schlemm's canal, and you can see blood coming from the inside of the Schlemm's canal. And then the point is that you can do with a suture with Proline 5.0 again, suture. But the problem is that it is you need to see, and here you are pushing so that you can help that with the gonioscopy, so that you can see the suture is going through the Schlemm's canal, so that it is not always easy because the Schlemm's canal itself has some anatomical variation, but you can assess with that, so that it is moving still. It is moving through the Schlemm's canal, but again, you confirm with gonioscopy because it can go into another space. So this is definitely a very economic surgery when you do it with just a Proline suture. But unfortunately, it is not always possible. You just rotate the Proline until you get it through the Schlemm's canal, so that it is possible to do that. But again, it is not. You cannot make it as the standard procedure because this is not always the situation. Again, you keep pushing until you get. And now I got the second end from here. I just wanted to show you there is some resistance. Yes, again, I have both ends of the sutures again, and you will confirm with gonioscopy all the time to make sure that the suture, and you can see the blue color inside, and then you will just get to have both. Okay, so again, you just held both ends and apply. Again, you will apply the tension, but you will see that that's beautiful to see that the eye looks like a breathing eye because there is a continuous tension on the Schlemm's canal again, and then again one trial, and then more than. Of course, you don't want to be so aggressive. You can do it aggressively, but the tissue is actually thin, so that you keep just. Yes, and now it starts to tear away through the Schlemm's canal, and then some blood can come through the Schlemm's canal. So again, so the point it is much easier when you do this with the illuminated catheter. It was just a demo, but actually, it is not routine to do it like that. It just show you that we can go for a circumferential surgery economically, but then actually. With the GAT procedure, when you go inside and then you cut the tissue of the Schlemm's canal and then you thread the suture and still until you get it from the other end, guided by the gonioscope. So this is one of the options. Just wanted to show you that there is a trend nowadays for the circumferential angle surgery. And the point is that when the circumferential angle surgery fails, you don't have to think of another trabeculotomy. You have to move to another option for solving the problem. So comments if
yes, it's a nice procedure, and we used to do this in Egypt before for the Proline suture, and the trick that was just to make the end blunt by using the cautery, so it will make it to pass easily through the Schlemm's canal. Yeah, and the other thing for the trabeculotomy, yes, we in Saudi Arabia are We are doing I am doing the viscoanalostomy, and then keeping the membrane trabeculodismal window intact, and using the trabeculotomy both sides. But the trick is, as you can see in the angle, there is a lot of bleeding, and the bleeding is the main cause of fibrosis later on. So I used to use Helon to tamponade the angle before doing the trabeculotomy, and after doing the trabeculotomy, I am just doing tamponade again the angle with the Helon, so you will get rid of this blood clot and to get rid of the fibrosis later on. And I presented at SCRS 2015. It was called Visco Triple. Yeah, and I am working by it now to give the good results, especially in pediatric glaucoma. Yeah.
But do you do trabeculotomy?
No, viscocanalostomy, trabeculotomy. It is just finishing the whole viscocanalostomy, injecting the canal with viscoelastic by the Grishaber cannula, and then using the trabeculotome in both sides until the ostia of the Schlemm's canal only. I am not passing over the trabeculodismal window. So keeping the trabeculodismal window at the end intact, so it acts like non-penetrating glaucoma surgery at the end.
Yes, sure.
So from the first day, the AC is formed and no fear of collapse.
I think another advantage of the deep sclerectomy that it makes identification of the Schlemm's canal easier.
Yeah.
Because when you do the first flap, and then in the old days, you just cut the limbus vertically until you get to the Schlemm's canal, which is not always the situation inside the Schlemm's canal. But what makes you sure that you are inside the Schlemm's canal when you dissect a second flap, and then you will open the posterior wall of the Schlemm's canal the way we do in deep sclerectomy. So that again, another beauty of the deep sclerectomy here, that you are quite sure you are inside the Schlemm's canal actually.
The idea also, Dr. Ahmed, that we have to mention to our colleagues that this is a trabeculodysgenesis. So mostly our Schlemm's canal will be far posterior from the regular side. It will be something like 4 millimeter, especially in congenital or developmental glaucoma. Yes. You have to expect that it will be far posterior, not at the regular site for adult people.
Yes, variations, a lot of variations.
Yeah.
Yes. So any questions from the participants?
We have Dr. Mu'min, she raised his hand.
Yeah. Dr. Mu'min, yes.
Sure, for your tips to find the Schlemm's canal. Sometimes the anatomy is so much distorted, very large eyes, corneal diameter 14 or more. I find sometimes difficulty in those cases to find the Schlemm's canal. Yeah. What are your tips to find it?
And actually, it is, yes. And I think it is, sometimes you don't find the Schlemm's canal at all. And sometimes it disappears. And in one of the findings of the pathology of developmental glaucoma, you don't find the Schlemm's canal. Whether it is a primary or an outcome from the disease, they really don't know. But the point is, what helps in the identification of the Schlemm's canal is to do a second flap. That's the point. So that I do a first flap, but definitely the flap has to be thin because everything is thinned out in those eyes. So just do a second thin flap until it looks like a deep sclerectomy, and then in this way you are able to find the Schlemm's canal. So this is only my advice. Just make it like a deep sclerectomy flap, and it's possibly likely that you will get to Schlemm's canal.
Do I need to do some radial deeper cut down after doing the deeper flap, or it will be enough just to do the deeper flap?
I think if you do the deep flap, like the point is that we are combining deep sclerectomy with whether trabeculotomy or viscocanalostomy, so that if you are doing a proper deep flap, then you don't have to do anything. But the point is that if you do a deep flap that is a bit stereo or still above the Schlemm's canal, but definitely those eyes are a bit thinned out, so that you might not have the luxury to do 3 flaps. But you just prepare the second flap like a deep sclerectomy when you see the end of the sclera, the scleral spur, and then this is the Schlemm's canal. Now, if you just cross over the Schlemm's canal, then at that time you have to do a radial cut, as you have mentioned. But if you just open the posterior of the Schlemm's canal, then you are here.
So I still have a considerable rate of failure to find the Schlemm canal. In that situation, I go for a trabeculectomy. Do you have an opinion about that? In case of failure to find the Schlemm canal, is trabeculectomy okay? That's
in children?
Yeah.
In I think you have more than one option, because if the you know that if the eye is very virgin, and then you may try another surgical site. It is not necessary that if you can't find the Schlemm's canal, you can try in another quadrant. But definitely, you know that I don't like trabeculectomies they don't work. They really don't work. So that yes, you can do them, and there are some good reports in the literature. It's okay, but if you have a good eye, and then the point is, Dr. Mu'mina, it is much easier to find Schlemm's canal in the children. And the children with actually the disease is early, so that the eye is not so much distorted, because you know that the surgery for trabeculotomy is for those kids. So it should be easier to find Schlemm's canal in those kids. It is just, I think it's a matter of training. But if you don't find it in one quadrant, why not to try another incision?
Okay. I have a comment regarding using the Prolene. I tried it twice actually, and I think in both times it ended with I couldn't retrieve the other end. I went with I measured the estimated length that I should pass for the Prolene, and then I found that I can't retrieve the other end, so I aborted and used the trabecutome. Yes. So as you said, sir, it was a scary situation for me, because this maybe I passed in the suprachoroidal space or something. Yes. So I was like keeping my hand on my chest at the post-operative period, because I was so scared. Yes.
It's not will that, I find something in the retina or not?
Yeah. So is there any? I know it could be considered a commercial question, but is there any news that the catheter will be soon in the market, in the Egyptian market?
I really don't know. I know that the شركة الفاطمية they used to bring the probes. And then those illuminated the catheters, and I think for years, and then they stopped bringing them. I really don't know why, but you might. But because the idea of having an illumination in the tip of the catheter is really brilliant. You know where you are all the time, actually. So that as far as I remember, it was from Fatimiyya. We might ask them again. But you know that I know your feeling when you keep pushing and then nothing is coming out. I know your feeling. Then shall I continue? Shall I withdraw?
I had an attack of extrasystole.
I really understand this. And I think it's not harmful, because you can go in the supra. It is just somewhere above the pseudo body. But I think the point is that if you decided to do that, you have to put the gonioscope, so that you see where you are. You can see the blue color of the suture, and otherwise I think it's not easy to do. Yes.
Okay.
For this case, if you are not sure that the lens is enough, from the beginning you have to measure the diameter of the eye and get the circumference. So and make a mark on your thread, not to pass too much. So you will be sure that if it is going to go ahead or not. For the catheter, when they invent the hydrus, I talked to Stegman, and I told him they were promoting it. They were before promoting the canaloplasty, and says this is marvelous, and this is our target from glaucoma surgery. And when they have the hydrus, they go, this is extremely marvelous. Even it can work in congenital glaucoma and any glaucoma
Yes.
types. And so at the end, it is an investment. So they are the owners of the or sharing in the companies that manufacturing the canaloplasty, and now they shift to the hydrous. So it become there is a shortage now because of this. There
Yes,
is not
yes.
they are not
So
promoting
the
it
same company
anymore.
is now producing the hydrous implant.
The hydrous, yeah.
That's a secret. Yes, thank you very much.
Yeah.
Thank you. Dr. Ahmed Yahya is wants to ask
Yeah.
something. Yes,
Dr. Ahmed.
Ahmed.
Dear Professor, sometime you may saw kids with the congenital glaucoma with the advanced stage with the ophthalmos or some sort of the corneal opacity. Did you still do a trabeculotomy or some sort of other types of the surgery?
Dr. Ahmed, and usually I'm so much disappointed regarding the results of trabeculectomy when the patient is having a coexisting corneal scar. Because the cornea might be opaque from the disease itself, but sometimes the cornea is not. This could be Peters or other forms of anterior segment dysgenesis. I'm so much disappointed from the results in those situations. So that I think if I have a large globe like that, I would give a chance for a combination of trabeculectomy and the trabeculotomy. I just give a chance for that. And then if it does work, well and good. If it doesn't work, and this is the usual situation, I go for repeat diode cycloablation.
You didn't do implant tube shunt?
I don't like the implants in the kids. You know that it's a bit. It's not easy decision to take actually, because if the cornea is scarred, then you know that the tube will might add more harm to the cornea. And then if the future, if you need to do a keratoplasty, you have to think what are you going to do with the tube. So that if the cornea is not clear, I don't opt for a valve. I usually go for diode laser, and I just tell the patient we will do it repeatedly until the pressure is satisfactory. And we have good results from the micropulse treatment, so that I may go for repeat treatment if possible. But I think valve is not my priority in those sides.
Thank you very much.
Thank you. You're welcome. Dr. Islam, I think it's now more than 2 hours.
Hours, yeah.
I think I'm so bad.
No. It was a very nice, informative lecture. And يعني thanks for your time, Dr. أحمد. بصراحة يعني من المحاضرات الممتعة وربنا ينفع بيك دايما ويجعله في ميزان حسناتك يا رب.
اللهم آمين يا رب. Thank you very, very much. I really appreciate very much the invitation and the company. There are a lot of the attendants. I know them. And definitely there are some participants who always keen to learn, like Dr. Ahmed Khalaf. I see him frequently. I'm so happy also to meet a lot of new colleagues through your program. So thank you really very much. Thank you very much.
Thank you, Dr. Ahmed. Thank you very much, and thanks for all of you. Just to remind tomorrow that we have a lecture from Dr. Walid Tantawi. His lecture will be about neuroimaging in normal tension glaucoma. It will be at 7 p.m. Saudi Arabia, 5 p.m. Greenwich Mean Time. And hope to see you tomorrow إن شاء الله. وشكرا دكتور أحمد، جزاكم الله خيرا.
شكرا جزيلا.
وفعلا استمتعنا النهارده بالمحاضرة، وربنا يعني إن شاء الله نجتمع في محاضرات قادمة إن شاء الله رب العالمين.
إن شاء الله.
ندعم حضرتك بس يعني ده أملنا في حضرتك دكتور.
Thank you very very much. شكرا جزيلا. شكرا. إلى اللقاء. السلام عليكم.
السلام عليكم.